Hello. Mr. David Nazal has presented to the ED at 2200 hours. On assessment, he was found in a tripod position and with a barrel chest. He has a history of COPD which exacerbated the previous year, and he is day 3 of COVID-19 positive. In the past, he has had hypertension and hypolipidemia. David Nazal was a chronic consumer of cigarettes but stopped on COPD diagnosis 10 years ago. Additionally, he was self-medicated with managing his exacerbation of COPD with a Ventolin inhaler. However, it has stopped being effective in the last few days to provide relief to Mr. Nazal. He is also reported to have excessive mucus production. Talking about the A to E assessment as mentioned in the case study, one can deduce the following. Airways. Currently, the airway is patent due to David being able to produce cough. However, the airway is not clear as the mucus, which can be observed in the form of yellow phlegm, is not completely removed from the airway. This is a common indication of inflammation and infection in COPD patients. Likewise, COPD patients often struggle with oversecretion of the mucus, and this can block the air passage partially and even completely on exacerbation. Thus, this indicates that a nurse can have a clinically apt decision of preparing the mucus suction to aid in clearing this airway, if in case it does get worse. Next one, we can also observe that for his breathing, Mr. Nazal is under immense respiratory distress. His respiratory rate is tachypneic and abnormally rapid at 30 breaths per minute. Additionally, his SpO2 is critically low at 78% on room air. Instead of being between 95 to 100% for a normal individual and for a COPD patient, the SpO2 being between 88 to 92%. This indicates an immediate call for action and for nurses to initiate oxygen therapy, which will be further discussed later in this presentation. Likewise, Mr. Nazal also shows signs of bronchoconstriction and buildup of fluids as one can hear crackling and wheezing sounds while he breathes. More signs of COPD exacerbation can be observed when analyzing David's arterial blood gases tests or test results or ABGs. On analysis, one can conclude that he is hypoxemic and his PaO2 is at 55 mmHg, and he also exhibits hypercapnia signs because of a higher retention of CO2 at PaCO2 being 60 milligram 60 mm per Hg. Both of these are exacerbation symptoms of COPD patients. For circulation, Mr. Nazal's cardiac system is under tremendous strain, and this can be deduced from his sinus tachycardia and a heart rate of 128 beats per minute. Additionally, a systolic hypertensive blood pressure of 168 over 85 mmHg is also observed, whereas his capillary refill is more than 3 seconds, along with cooler extremities, which indicate that further his perfusion rate has reduced, which may be secondary to hypoxia. Furthermore, moving on to his disability, his GCS is reported to be between 14 to 15 due to him being mildly confused. This neurological alteration may have been caused due to a lack of available oxygen and increased CO2 for his brain to operate at efficient rates or hypercapnia. This change in psychological state must be closely monitored to aid in immediate management and avoid further deterioration of his current state. Lastly, exposure. David is febrile, thus presenting with a fever, which further indicates the activation of immune system to fight an infection. This infection is due to the recent addition of clinical history and COVID-19 infection, which may be confirmed on assessment of chest X-ray results as well. Next up, the first nursing intervention that we will be discussing today is administering controlled oxygen therapy. In order to avoid oxygen-induced hypercapnia, a venturi mask can be used to titrate the SpO2 between 88 to 92%. The rationale is excessive carbon dioxide levels or hypercapnia and low oxygen levels or hypoxia are common signs of exacerbated COPD. It is paramount to manage David's oxygen as further complications in his state may require immediate medical attention and, interventions. Sorry. On keeping his SpO2 between 88 to 92%, nurses can avoid further respiratory failure and reduce the risk of oxygen-induced hypercapnia. Additionally, the venturi mask is preferred because of accurate control over the rate of oxygen delivery and concentration, and it is widely used to prevent fluctuations that may end up in adverse effects. The second high priority nursing intervention is administration of salbutamol in a combination with ipratropium, which is another high priority intervention. Using salbutamol every 2 hours and ipratropium every 6 hourly, the frequency of bronchospasms can be immensely controlled. The rationale: salbutamol is a short-acting drug that is used to relax the airway muscles, whereas ipratropium is a drug that is usually used to prolong the bronchodilation effects. In combination, these bronchodilators work to improve ventilation, reduce airway resistance, and decrease the work of breath, which is quintessential in alleviating effects of a COPD patient. Thirdly, a high Fowler's position. Mr. Nazal may adapt high Fowler's position, which essentially aids in lung expansion and allows slight reduction in the use of intercostal muscles during work of breath. The rationale behind this intervention is that it increases the oxygenation by providing more movement to the diaphragm and reducing the pressure on the diaphragm. This position is extremely impactful in patients who have heavy respiratory distress, such as those who suffer from COPD, as it also facilitates ventilation and aids in reduction of work of breath. This is a non-invasive intervention which increases the patient's comfort and respiratory status. Lastly, regular monitoring of ABGs is another high priority nursing intervention which may be used in Nazal's case. This can be achieved by analyzing and closely monitoring ABGs every 4 hours to look for gaseous exchange and adjusting the oxygen therapy as per requirement. The rationale behind this is for COPD patients, regular monitoring would allow early detection of worsening of hypoxia and hypercapnia. Furthermore, monitoring is vital in evaluating interventions, guiding decisions, and avoiding the chances of respiratory failure. Next up, oxygen therapy. Assessment. In order to prevent hypercapnia, it is paramount to monitor SpO2 and PaCO2 levels, regularly assessing the respiratory rate, work of breath, and respiratory fatigue. Administration. Nurses can administer oxygen therapy using a venturi mask to keep the SpO2 between 88 to 92% and titrate it to avoid oxygen-induced hypercapnia in COPD patients. Side effects to look out for: one should be able to look for signs of confusion, CO2 retention, drowsiness, decreased respiratory rate, all of which ultimately leads to respiratory acidosis if not treated. Ventolin or salbutamol. In order to check the effect of drug on bronchodilation, one can check the respiratory rate, heart rate, and if the lungs are making any sounds to detect any adverse reactions. Administration. As per prescription, salbutamol can be administered every 2 hours using a nebulizer. For maximum results and alleviation of COPD effects, nurses can ensure that David is in an upright sitting position, which would facilitate lung expansion whilst administration. Side effects. The common side effects of this drug are due to its beta-adrenergic stimulations, which are manifested clinically in the form of tachycardia, palpitations, and even tremors. Nurses must monitor the vital signs and further escalate tachycardiac activities and complaints of discomfort by David. Next up, atrovent or ipratropium. Assessment. To determine the effectiveness of anticholinergic effects of this drug on respiratory smooth muscles, check for lung sounds before and after nebulizer has been administered. Administration every 6 hours using a nebulizer. Side effects. In older male patients, urinary retention is a very common side effect, whereas dry mouth is a side effect which is observed in all subsets of patients. Nurses may monitor complaints about discomfort during urinating. Prednisolone. Assessment. This drug may cause hyperglycemia, thereby David's BGLs must be closely monitored and regularly conducted. Nurses may also search for signs of infection such as fever and redness. Administration. 40 milligrams to 50 milligrams orally once daily must be continued as per charted. Nurses must emphasize the importance of completion of this drug order as it is a steroid and it must not be abruptly stopped without medical consultation. Another thing for nurses to consult with the doctor would be the drug route, as David is nil by mouth and this drug must only be taken by oral. Side effects: gastric irritation, increased susceptibility to infections, and hyperglycemia are the most common side effects of this drug. Administration of a proton pump inhibitor may also be considered by the nurses to aid in pain relief if David complains of any gastric discomfort. Azithromycin. Assessment: monitor signs of reduced sputum and David becoming afebrile via vital signs, specifically temperature. Administration: drug may be administered through IV and then followed up with 4 days of oral doses. However, David must be briefed about completing the drug course to avoid antibiotic resistance, and doctor consultation must again be done as he is nil by mouth. Side effects: nausea, diarrhea, and other gastric disturbances are the most common side effects of this drug. However, regular ECG must be conducted to check if there is a QT prolongation, which may indicate a rather severe risk of this in this drug class of azithromycin, which is macrolide antibiotics, a very common side effect. Nirmatrelvir and ritonavir. Assessment: nurses must ensure that David's renal and liver functions are normal. This can be achieved by laboratory testing, as both of these medications are metabolized by liver and excreted by kidneys. Administration: nurses may administer this combination of drugs BD orally for 5 days as per the COVID-19 treatment protocol. The most common side effects are gastrointestinal disturbances such as vomiting and nausea. Ritonavir must be closely monitored for drug interactions due to it possessing the ability to inhibit cytochrome P450 enzymes, ultimately altering the drug-on-drug metabolism. Thank you.